I am Dr. Lisa Tartaglia.
I'm Dr. Baum.
And we're coming to you today to talk about our wonderful
Yodo.
But is that really true? Do you only die once?
You can die more than one time. And that's what we're going to visit about today is should you die more than once? And why would somebody choose to die more than once? And how would you die more than once? I think the most obvious is CPR.
Right. Do you all know that CPR starts when someone has already passed?
This is so true. A lot of people get really worried about CPR, but I have to guarantee you we only do it to people who are dead. For most people, if whatever is going on with your health is so severe that your heart stops, probably resuscitation is not going to return you to your prior quality of life.
Absolutely.
It's a lot of compression because the goal is to press your heart and squish it between your sternum and your spine. And so you're trying to mash that so that the blood will pump through. And if you get the proper response and you don't have a lot of other health issues, then CPR may revive you. But will it revive you to the quality of life that you had before?
Well, oftentimes it doesn't. Because if the CPR is delayed in any way and there's not good blood flow to your brain in the process of dying, sometimes you do not come back in your cognitive ability. And then I would also like to touch on when you're getting CPR. It's very common for your ribs to fracture because you are big. Yeah, right, pressing down and
quickly and firmly.
Yeah. So it can cause some pain.
Well, no, you're dead.
No, that's true.
If you're revived, you may have pain. But during the process of CPR, you are dead. And so running 360, volts, joules through your body doesn't cause you any pain. Getting the chest compressions themselves doesn't cause you any discomfort. But if they're successful with the resuscitation, then you might have, in the process of receiving that life-sustaining treatment and intervention, you might have had some fractured ribs. You might have possibly, gotten a lung that may have collapsed. You might have, gotten injured to, other body organs. Maybe you were busy when you collapsed and you were up on a ladder, so you fell and broke your hip as well. If you're in the hospital, it's usually a witnessed arrest. You're typically on telemetry. But my question becomes then, why are you in the hospital, and are you already, suffering from some illness? Are you already in the process of succumbing to some other illness? And is CPR in your best interest?
Yeah, and I'd like to just explain telemetry means that you're already being monitored. Your heart's already being monitored. They're already monitoring your respirations. They're already monitoring your oxygen level. So that's why that's an ideal situation to have a cardiac arrest, because
ideal situation. A little irony there.
Yeah, exactly.
There's no ideal situation, but I know what she means, because you're now in an ideal environment. There are success stories, but not by the majority. The majority of people do not do well with CPR. The majority of people do not do well after CPR.
Right. And I think that majority is a sicker population. They have chronic conditions. They're not responding to treatment, and that's why they have the arrest.
So not receiving CPR is a choice that a lot of people made, and I think Dr. T already shared that she's a DNR. She has elected that if her heart should stop for some reason, she does not want to be resuscitated, and I actually have a DNR sign that I actually carry around with me, because I have seen what can happen when somebody does receive CPR and they stabilize, but they don't return to their prior quality of life. And that's a frightening thing for me, because I've actually seen that dirty side of healthcare often. If everything goes extremely well, they do the chest compressions, they administer medications, they provide the jolt of electricity through the body to try to restart the heart, and the heart restarts, they begin to breathe again.
Generally speaking, after you've had CPR, most likely you go onto a higher level of oxygen. You don't normally just come back and you're smiling and you're ready to go out and mow the lawn.
Just receiving the CPR, it doesn't necessarily stop there. And some people have very strong feelings about some of the life-sustaining treatments.
Mm-hmm.
And we do call them LST, life-sustaining treatments, because that's exactly what they are. They sustain life. They don't restore life. They don't promote life. They don't save life. They sustain it. And so the most common one, of course, is CPR, and then probably the next most common is the ventilator.
Mm-hmm. Yes, and the ventilator is something where people that are not medical might think, oh, I'll just, get my
I'll put me on a ventilator for a little while.
Ventilator for a couple days, but they don't really realize that their lungs are not perfusing, they're not able to breathe on their own, and their heart is no longer perfusing properly. So it's causing a lot of discomfort, and they are, they have a tube into their mouth usually that goes into their trachea to put air in, but that tube can only stay in for a short amount of time. Mm-hmm. And then you're looking at having a trach put in, which is a cut usually through the neck that goes into your trachea, and that is also very cumbersome. But a lot of times, doctors will just say, oh, yeah, we're going to put a trach in today.
Mm-hmm. And so it seems really commonplace. And I think in 2020 and in 2021, I think ventilators got talked about a lot. Mm-hmm. I think there was a period of time where companies that didn't ordinarily make ventilators made a lot of ventilators just to have those on hand because of the COVID crisis.
Right.
And I think that with the talk, it sounded like being put on a ventilator was not necessarily such a bad thing. But if you look at statistically, people who get put on ventilators, what happens to them in the upcoming months and potentially years if they survive that ventilator treatment, it's not a great quality of life for some of those people. I know their families are delighted that they are still living, and I want to put that in perspective because the patient may feel like I might be alive, but I don't feel like I'm living, being in this bed hooked to that machine. Mm-hmm. Because the ventilator is not just supplying oxygen, but it is actually forcing air in and letting the natural reaction of the chest to relax and collapse. It's not sucking the air out, but it forces that air in and pushes it in, and that's why there has to be such a tight seal either around the nose and mouth, or there has to be the tight seal of the cuff in the trachea.
As Dr. Bone said, that patients stay on, there's a period of recovery for several days, so when you are not able to breathe on your own and you have a tube in your mouth, you obviously cannot eat, right? So that's another thing that just seems to kind of just go by the wayside, that people don't really think of the importance of eating. You start out with IV hydration in the short-term interim, and then we will change to different methods of feeding. You work more in the inpatient setting now, so usually they'll have a peripheral IV, and then maybe a central IV for feeding, but that can only be done for a certain amount of days.
And we don't like using that TPN, total peripheral nutrition. We don't like using that really because the best way to get nutrition in a person is through the gut. And so we can artificially feed with artificial nutrition that goes in through an IV, but that's a very short-term fix, if you will. It's just for a very brief period of time because there are a lot of potential side effects to TPN. And so we don't really like going to that. They'll use what they call trickle feeds, which may be a small skinny tube that goes in through the nose and down into the stomach, and it just gives a continuous supply of formula that is basic nutrients into the stomach so that the patient can receive that nutrition. And they will typically start that pretty quickly because the patient should not get into a nutritional deficit.
What happens after several days, normally 10 to 14 days, and then the patient's still not eating, not responding to being weaned off the ventilator, meaning that they try to lower the settings to see if the patient could breathe on their own. Now what happens?
Well, if they've been on that ventilator for a long time, they tend to get weak. Even though we've been giving them this artificial nutrition, now we have some other issues because the patient has reached a new point of homeostasis. I think there's two really important times in your life. I think when you're born and when you die. And you get lots and lots of time, maybe up to 6 months, maybe even longer before there's a birth, but you may not get that much time before a death. And if you're going to die more than once, there are a lot of potential risks associated with
and you
that.
have to look at, is the risks and the burden of these things worth it? And that's why it's really, really important to have these conversations while you're still well of what you would like your dying to look like. And if you want to die once, you want to die twice, you want to die 3 times, you can. But just you want to look at what the burden potential is, in the future.
You do have choices as to whether you want to receive the life-sustaining treatment. I think a lot of patients, when they go to the hospital, they are approached and said, and so what's your code status? Like it's just that easy, like kind of, going up to the window to order a Big Mac, What's your order? What do you want? You don't want to be resuscitated, do you? It's almost like they're being trying to talk in or out of something. It's a really complicated, complex decision. And I know that when nurses and physicians approach patients, they may be limited in their time that they can spend with that patient. And they're hoping the patient already has those things decided. So it's not that they're trying to talk a person into or out of something. They just want to know, what are your beliefs? We've got a limited amount of time here before we really need to act on what's happening. And I want to make sure that I understand what your position is on these certain life-sustaining treatments.
Right. And I think it's really important to have that done, like Dr. Bone said, before you go in the hospital. I know for my team that I work with, they'll always start every conversation with me, well, doctor, they want everything done. Well, what does that mean? Because I think if people really knew what it meant, would they really want it, right? Some would, and some would not.
I think some people fear that if I elect a do not resuscitate, then I'm eliminating all life-sustaining treatments from this moment forward. And, I just want to reassure people that is not how it's supposed to be at all. Yeah. I don't want to remove anything from the patient. And what I try to reassure patients is if you're able to respond to me and tell me, my heart feels funny, I want to go to the hospital, I'm short of breath, I want oxygen, I'm hungry and I can't eat, we will find a way to feed you if you're hungry and you can't eat. The life-sustaining treatment choices are to be in place for the time that you can no longer communicate, that your disease has now advanced to a point where you are unlikely to ever be able to regain that ability, and it's meant to guide the team that is caring for you, your physicians and nurses, and guide your family as to what's important to you as the end of life approaches. Because some people do really prefer to only die one time. They don't want to be resuscitated, and I came back and I have a lower quality of life. And then I was resuscitated again a second time successfully, and that time they did break some ribs, and it took me 6 months to recover, and I have not been out of the wheelchair, and I rarely leave my house now. So, yes, those were successful resuscitations, but did you return to the prior quality of life that you've had before, and is that what you want?
And I just always like to relate to stories of what patients have told me. And I feel like when you educate them and they understand, they are so much happier making the decision. They feel more relaxed about it.
Because a DNR
does not mean do not treat.
Yes.
It just means when you die,
you die.
Yeah.
And we want to enable that dying process to be comfortable, to be natural. We would like your family to be there. When asked, most patients say, at the end of my life, I don't want to be in a hospital. I want to be in my home. I want to be with my people. I want to be with my things. I want to be around my pets. I want to look out my window. At my last hours, I want my family with me. Being in a hospital is not a great place to be when you've got bells going off all the time. You've got people coming in wanting to take your blood because now it's your time for another blood check. You don't want to, have that narrow bed with those scratchy sheets and IVs and tubes going in and out of every opening on your body. That's just not peaceful and not natural. So we want to educate our patients so that they know what those choices mean and what they're deciding. But DNR, do not resuscitate, does not mean do not treat. It does not mean do not care. We want to care for people. There is a lot that can be done for people who are approaching the end of life.
And there's a lot of treatments, right?
Mm-hmm. And that's not giving up. And it's certainly not less care.
Mm-hmm.
To be facing the end of life is extremely serious. It's so serious that the federal government, CMS, the Veterans Affairs, they all have hospice care that is covered by nearly every insurance. And if a hospice organization accepts money from those payers, they have to provide a certain amount of charity care.
Mm-hmm.
So when a patient goes on hospice, they are not to just be just given medication for pain and shortness of breath and have all their other medications taken away. They are to be cared for, and they have an entire team that is to care for those patients who say, I'm a DNR and I want to be at home. And I think one of the beautiful things about, having serious illness, facing the end of life is, yes, you are afraid, but you have an entire team to assist you now.
Exactly.
So a DNR is not do not care, do not treat. A DNR is do not resuscitate. And I want to pass peacefully and I want to be comfortable at the hour of my death.
And as I said in the beginning, it doesn't mean that you're going to die today, tomorrow, or always. Both of us, we've shared with you, we're DNRs and we're living life to the fullest.
Yeah, I want to live every day that I possibly can, but when my time is up, then I'm ready to go. Because being alive on a machine, to me, is not the same as living. So life-sustaining treatment choices, CPR, and some people feel like I will take the others, but if my heart stops, do not do that. Some people feel like I, will take CPR, but if I wind up on a ventilator machine, if I can't breathe for myself, my family knows they've got to find a way to make me comfortable and turn that machine off, because I don't want to be kept on a breathing machine. Some people feel like, I'll try a transfusion. You can do that a few times. I'm willing to do that, but I don't want those other two things done. So it's kind of a cafeteria where you can pick and choose the life-sustaining treatment that you want. Some people feel like it's a blanket. I don't want any of them. I read those cases. I've heard of Nancy Cruzan. I've heard of Karen Ann Quinlan. They've heard of some of those landmark cases, and they fear that chronic vegetative state. I can tell you it's extremely hard on a family.
Very hard.
To have a loved one in a chronic vegetative state, because then you're forced with these terrible decisions. It's a tremendous burden to carry.
Yeah, and some of the decisions are not just decisions to make with healthcare, but the financial burden. There's so much. I mean, they require tons and tons of higher level of care, which of course costs money. And then most of those times, those people are not in their home, so the family has to venture out to see them. It's just extremely devastating. So you really have to look at it. And I think what we're trying to say to you all is, really look at what you really want. Don't be afraid to say do not resuscitate, because that does not mean we will not treat you. No physician will just stop all treatments. That's not what we do.
That is not what it is supposed to be. And if somebody tries to tell you that, we really want to talk with them, because that is not what a DNR is supposed to be about.
Yeah. And we would really be interested in your comments about this topic, because I think that this is really a topic that not a lot of people like to discuss. And
you can certainly change your mind.
Yeah.
You may have gone to the doctor and you had a great day and you're thinking, I would try those things. And then you think about it, or you read about it, or you check Dr. Google and you thought, I don't know, that does not sound like what I would want, because the procedure itself might not be so bad, but I'm afraid of the aftermath. I don't want to be around with that kind of lingering illness.
Right.
What I want to impress is we have the technology. We can't make a person live, but we can certainly sustain and forestall that death.
And honestly, sometimes I look at it as a double-edged sword. When I'm with patients, I often go back to talking to them about when their grandparents have passed, or what did they want? They wanted to be in their bed, surrounded by family, sipping on some soup, if they could still eat, looking at the beautiful home, and taking it all in. So we have a lot of interventions that have helped medicine, and helped people sustain. but then it's also sometimes taken away the dying process to be beautiful.
2020, 2021, and in 2022, we saw families separated from their loved ones at the end of life. And it, from my standpoint, it has been truly heartbreaking. And I want to go down now on record as saying that I think what we have done has been wrong. I think to remove patients and families from each other at the time of death has been wrong. Now, do I have a solution? No, even looking back in hindsight, I can't tell you how we could have done it differently, because people were exposed to a very potentially lethal viral illness, and the ones that had that illness, we had no way to protect the people who cared for them, and we had no way to protect their families. Some entire families got that terrible virus. But separating people at such an important point in their being, in their existence, to separate them at that moment in life has just, left scars upon my heart to hear these stories from family members who lost their loved one and they weren't there with them. They weren't able to spend time with them. And so there's got to be a better way for us to die. And I don't know that dying more than once is the answer.
Right.
I think if we know we have a lethal illness, I think being able to be in our own home for those last days and hours of our life, and to be able to be comfortable with our family members, I think that's a beautiful thing.
I agree. Have a healthcare surrogate. Have your wishes known. Know what you would like your final days to look like, and be as educated as you can while you're healthy.
So life-sustaining treatments are just that. They're treatments that sustain life. They don't save life, but they can prolong that dying experience sometimes. There are definitely success stories. I have heard many success stories, and I'm sure each of you know of a success story. And what makes those so noteworthy is they don't happen that often.
Right.
I'm sure what we talked about today was very controversial.
Yes.
And so we do want to hear your comments and know more about what you're feeling and what you're thinking and what's in your heart, because that helps us learn so we can communicate with others, because we want to learn from you and we want to teach.
Yeah. Thank you all for joining us, and we'll see you again soon.
Thank you.